Hello, and welcome to today's webinar hosted by the Texas Association for Home Care and Hospice. My name is Liz Gallagher, and I'm a paralegal at Lyles Parker. Today's webinar is Value-Based Purchasing and Alternative Payment Methodologies. Where does your home health agency or hospice fit into delivery system reform? Today's presenters are Michael Cook and Heidi Kocher. And without further ado, I will pass it over to our speakers.
Good afternoon. My name is, as Liz has mentioned, my name is Michael Cook, and I'm a partner and the co-chair of Lyles Parker's healthcare group, working out of the Washington, D.C. office. I've been representing healthcare-related clients for more than 40 years, and before that, at the start of my career, I represented the federal regulators of the Medicare and Medicaid programs as an attorney for the United States Department of Health and Human Services. And during this period, I've headed DC offices of healthcare practices of major national and international law firms before joining Lyles Parker. And I've represented virtually every segment of the healthcare industry with a strong emphasis on regulatory compliance and investigations, business and policy issues. Frequently before state and federal regulators. I'm a fellow of the American Health Law Association and also the chair of the board that oversees Virginia's Medicaid program as an appointee of Governors McAuliffe and Northam. And I've advised campaigns of candidates for both state and federal offices on healthcare related issues and have served on the healthcare transition teams for the prior three governors of Virginia. Heidi, do you briefly want to introduce yourself?
Sure. Hello, all. My name is Heidi Kocher. I'm also a partner at Lyles Parker, and I am officing in the Dallas area, so Texas resident here. I have over 20 years of experience in healthcare and regulatory law, representing providers of all sizes and types, have been working a lot with home care and hospice, and this is of a particular interest to me because I've been on the other side, having been a consumer of home care and hospice for my elderly parents. So I think home care and hospice personnel are underpaid and saints on earth, and this has made the work that I do with folks in home care and hospice that much more important. So I look forward to giving you some more information about the value-based purchasing today.
Liz, can we move the slides? Obviously, this is a disclaimer that it doesn't constitute legal advice, and you should be, and that you should seek legal counsel for specific legal advice that you may have, but it is for educational purposes. Next, Liz. I'm going to begin the presentation by briefly discussing how we got here and why alternative and value-based payment methodologies are almost certainly going to be the wave of the future. Also, because the value-based purchasing demonstration at home health is being expanded nationwide, Heidi and I are going to spend the vast majority of our time discussing that program. However, we've included slides on the Comprehensive Joint Replacement Program, the Medicare Shared Savings program with accountable care organizations, and the expansion of supplemental benefits such as home and personal care in the Medicare Advantage program, because they serve as good examples of programs where home health and personal care can play a major role. And also, you can access a much longer presentation by Heidi and I on the webinar that we presented on those programs for TAC in July 2021, and that can be accessed on our website. We'll also be very happy to answer any questions offline if you call us that you may have on those programs that we don't reach today. Next slide, if you could. All right, so how did we get here? Well, as I'm certain many of you know, The United States has by far the highest spending rate on health care as a percentage of gross domestic product in the world, of any nation in the world. And to give you a practical understanding of the magnitude of the issue, the U.S. spends about 18 to 19% of GDP on health care, while Switzerland, the second highest, spends about 12%. And a former secretary of HHR in Virginia once explained that difference, just the 18 or 19 to 12%, could fund 2 defense budgets for the United States, just as an understanding of the disparity. So there's been a tremendous emphasis under the ACA in piloting payment methodologies that incentivize delivery system changes that reduce costs while improving quality, and you're seeing a lot of that throughout the system today. And as part of the Affordable Care Act, Congress established the Center for Medicaid and Medicare Innovations, or CMMI, which was provided $10 billion over a 10-year period to fund pilot programs. And probably most importantly, the Secretary of Health and Human Services was given the extraordinary power to expand pilots regionally or nationally if the CMS actuary determines that they either improve quality without increasing costs or reduce costs without reducing quality. And currently, CMMI has implemented more than 90 pilots throughout the country, and CMS has implemented programs such as the Medicare Shared Savings Program through ACOs, value-based purchasing for certain providers, and the MIPS program for paying for physician services. Liz Fowler, the new director of CMMI, has indicated that there would be fewer and more targeted pilots in the future, and the new CMS administrator has indicated that we're likely to see more mandatory programs in the future as opposed to those that are voluntary in nature. And the expanded national home health value-based purchasing program pilot that got expanded nationwide and that we're going to be discussing is one of these. And the fact that we will be seeing accelerated emphasis on VBP, value-based purchasing, is demonstrated by the fact that the OIG and CMS recently published new and revised safe harbors and exceptions to the anti-kickback and Stark laws to accommodate value-based purchasing. My partner, Robert Lyles, and I did a session for TAC on the new safe harbors in May of last year, and Heidi and I will be doing a similar program for TAC in May of this year on both the new safe harbors on value-based programs and the new exceptions for those programs under Stark rules. A critical point to focus on, however, is that CMS was clear that these new exceptions and safe harbors do not apply to the home health value-based program that we're going to be discussing today, but they can apply to the other alternative payment methodologies for which we've included slides. Heidi, can we advance this?
Thank you, Michael. So this is basically just a slide to sort of indicate, I'm not going to go into it in depth. Again, we have a lot of material that we're going to go through pretty quickly. This just kind of gives you a background and information about how some of these different things all work together with the innovation projects and value-based purchasing, quality reporting, and so on. And you can see this is pretty complex. They're really trying to do a lot of work on this front. Next slide, please. Michael, did you want to tackle these real quick?
Just briefly, yeah, just briefly. We're going to skip over slides 6 and 7. You can take a look at them because they don't apply to this particular program that we're discussing, and because we're going to do a really comprehensive discussion on them in May of this year. We'll skip over them, and you can also listen to Robert and my discussion of the anti-kickback exceptions as well on, if you go to the Lyles Parker website, we did a webinar for TAC last year on that as well. Heidi, do you want to pick up on 8 and 10, 8 through 10
Sure.
now?
Yes. So as Michael said, what we really wanted to do was spend most of our time discussing the new home health, well, not the new, the expanded home health value-based purchasing. This was a model that they had been testing in a number of states, and because of the nationwide expansion and the COVID public health emergency, CMS actually ended the demo project a year early. And the most important thing I have highlighted here, which is, as with many of these demonstration and then subsequent payment programs that they have in place, alternative payments, you have a performance year, and then you have a baseline year, or actually you have a baseline year that serves as the standard against which you are measured, and then you have performance years. And for home health value-based purchasing, the baseline year is calendar year 2019, so before the pandemic hit in place. In other words, this is already passed, so they're going to use your past performance in 2019 as the standard against which you are going to be judged going forward. Originally, 2022 was supposed to be a performance year, but again, in light of how long the COVID pandemic is going on, they actually postponed this by a year. So 2022, in other words, this year that we're in right now, is a year for you all to get your ducks in a row and your systems in place. And then starting January 1 of 2023, it will be a performance year. And the data from 2023 will then be used to adjust the payments beginning in calendar year 2025. So really, if there's one thing that you take away from our discussions today, is use this year to get your systems in place. The one thing that the final rule also did was it amended the home health quality reporting program, and just a failure to report results in a 2% reduction in payment. So you want to make sure that you're reporting your quality statistics, not only because they go into calculating your performance year measures, but you get hit just by failing to report it. And we have a link down here for the final rule if somebody wants to sit down and read it until their eyes glaze over. Next slide, please. So briefly, again, this was a demonstration project in 9 randomly selected states: Massachusetts, Maryland, North Carolina, Florida, Washington, Arizona, Iowa, Nebraska, and Tennessee. And what CMS had said was they figured that these 9 states had enough variability in kinds of agencies and patients covered that it would run a good demonstration project. There were not quite 2,000 participating home health agencies. And again, the project started January 1st of 2016, and it was supposed to run for 5 years. It actually only ran for 4 years. But in the 4 years that it was in effect, the overall effect was savings of over $600 million. And they saw decreased hospitalizations, decreased SNF usage, and some minor increases in outpatient ED and observation stays. Originally, the payments were supposed to be adjusted up or down by 8%, depending on what your total performance score is. And we'll talk about that in a little bit. The key thing to remember here is that your OASIS data is the beginning point for all of this. So again, it's very important to make sure that you have your OASIS data entered correctly and timely and reported correctly and timely. Next slide, please.
Heidi, before we leave this slide, I'd just like to point out 2 things real quickly. First of all is that what they discovered also was that there was no effect on Medicare spending on home health. In other words, the savings resulted from the reduced hospitalizations and SNF usage, and they weren't offset because the outpatient ED and observation stays were much lower in amounts. And secondly, that was the basis that the actuary utilized to allow the expansion of this program nationwide. In other words, you had substantial savings, and not only did they notice that it appeared that quality was not reduced, but actually appeared to improve. So that was their basis. Heidi, go ahead.
Yep, thank you. Next slide, please. Oh, you got it already, Liz. Thank you. So basically, I'm just going to summarize the performance year 4, which was 2019. And this was published late spring of last year. So overall, your total performance scores increased by 8 points percentage points in the demonstration states compared to the rest of the country. And it doesn't sound like a whole lot, but that's actually a pretty significant increase in performance scores. And again, it kind of what underlays this is quality. Again, there were some mixed findings in 2019 as to whether or not there was a cost savings. Overall, over the 4 years, there definitely was. And in 2019, there were some gains in the quality of care, including greater improvements in functional outcomes, which tells me that as the folks began to figure out how all of these things worked, the patients had better outcomes. In 2019, there was no change in the home health CAHPS measures of the patient experience, which was kind of interesting. But what they saw was the changes in operations, again, were really focused on more accurate OASIS documentation, particularly at the start of the episode. And the agencies also implemented other quality improvement efforts, and they saw those bearing fruit. So as said, the model was so successful that when the pandemic hit in early 2020, CMS decided to end the project a year early. Michael's going to briefly start us into a deep dive now of what this looks for the expanded program.
Yeah, and one of the things that you might think about, one of the reasons why you might have seen a diminished level of savings in that last year is because, or of improvement in the OASIS scores, is because after a while you've squeezed out a lot of the fat in those states over time as you improve. And you may very well see that occur in the national scale, on the national scale as well, although only time will tell. Let's now talk about the expanded program, which is similar to the demonstration. There's going to be a payment adjustment in what Heidi has mentioned to you or referred to as the payment year, based upon the level of quality that the agency provides in what is referred to as the performance year compared to its peers. As we'll explain later, there are two ways that the agency will be measured. The first is in performance on quality compared to its peers in the performance year, and that's referred to as the achievement performance category. And second, in the improvement that it makes in its quality in performance over the baseline year, which is called the improvement performance category. Basically, the agency's performance will be measured in what Heidi has mentioned is referred to as the baseline year. And for those agencies that were Medicare certified before 2019, this is going to be calendar year 2019. For newer agencies, the baseline year will be the first full calendar year in which they were Medicare certified, except that for agencies whose first full year of Medicare certification was 2020, the baseline year will be 2021. And the reason for that is CMS skipped 2020 as a baseline year because of COVID, which thoroughly distorted any fair comparison with the so-called normal year, and also because, as you folks all know, the data submissions were curtailed, some of the data submissions during that year. Now, the first performance year under the expanded program, as Heidi's mentioned, will be calendar year 2023. And this is the year in which the agency's performance will govern an up or down payment adjustment for the payment year, which is 2025. And the maximum payment adjustment for 2025 is going to be 5% in either direction, which can be a significant amount, obviously. For future years, the performance year will be the calendar year right after the baseline year. CMS is using 2022 as a pre-implementation year, or as Heidi would tell you, a dress rehearsal for agencies to prepare for the value-based purchasing model. And during this period, CMS is going to be providing education and potentially, to the extent feasible, reports to the agency on their performance during that year, both against their competing agencies and themselves, although that's not guaranteed to do so. There's a lot of work that they're going to be doing during this year and may not have that option. Can we move to the next slide, Liz? As we mentioned, the model will be expanded nationwide. Under the demonstration, agencies in the 9 states were measured against and competing with agencies in their own states. However, under the expanded model, agencies will be competing against other agencies in their cohorts nationwide. And the reason for that is that CMS isn't limiting the comparisons to agencies in their own states or district is because in several jurisdictions, such as the District of Columbia, there simply were not a sufficient number of agencies to provide a statistically valid comparison. Also, while being measured nationwide, the agencies are broken up into 2 cohorts for comparison. The first is the larger volume-based cohort, which consists of agencies that administer the Home Health Care Consumer Assessment of Healthcare Providers and Systems, known as the HCAP survey, and namely those that have 60 or more unique HCAP survey eligible patients. For the base year 2019, there were a little over 7,000 home health agencies that fell within this cohort. And the second cohort is what is referred to as the smaller volume-based cohort. And these are home health agencies that are exempt from administering the HCAP survey, namely those that have fewer than 60 HCAPS eligible patients. And there were 485 of these agencies nationwide that fell into this cohort during the what I call the baseline year. So as you can see, the vast number of agencies fall within the large volume-based cohort, and you're compared to all other agencies that fall within your cohort and not to agencies in the other one. I would also mention that while agencies that fall within the smaller volume-based cohort by definition are exempt from administering the HCAPS, they're required to submit their total number of unique HCAPS eligible patients to CMS just to make sure that that they're properly categorizing themselves. Liz, the next slide, if we can. The chart on this slide is taken from the preamble to the final rule and simply lists the various baseline performance and payment years based on the Medicare's certification date in a simple fashion. And as you can see, they're skipping 2020 entirely because of the COVID year. Let me turn it over now to Heidi, if I can.
Thank you. So what we're going to dive into now is a little bit more in depth in the model. So as we've said, there are some very important things that you'll need, and what they are doing is using these quality measures to calculate your improvement and achievement scores, which then roll up to your total performance score. The quality measures are based on the 6 national quality strategy priority areas, which are clinical quality of care, care coordination, population and community health, efficiency and cost reduction, safety, and a patient and caregiver-centered experience. Next slide, please. This table specifically shows you the 2022 quality measures that they're going to be using. And presumably in 2023 and 2024, although we can talk about that. As you can see, these measures are categorized into 3 different categories or 3 different buckets. The first category is OASIS-based, and they're looking at improvement in dyspnea or dyspnea, discharge to the community, improvement in management of oral medications, and the total normalized composite change in self-care and the total normalized composite change in mobility. So those 5 elements come from OASIS. Then they're looking at 2 claims-based measured. The first is the acute care hospitalization during the first 60 days. So in other words, does the patient end up going to the hospital during the first 60 days of home health? And that's going to be abbreviated ACH. You'll see that a little bit later on. And the second claims-based measure that they'll pull simply from the claims record is ED use without a hospitalization. And then they're looking at 5 components from the HCAP survey: care of patients, communications, specific care issues and team discussions, overall rating of the home health care, and the willingness to recommend the agency. So 5, 2, and 5, so 12 total measures that they're going to be using in 2022. Next slide, please.
Let's jump in here real quickly. Just one other point here. I've heard if you take a look at the HCAP survey-based ones, I've heard a consultant talk about the fact that one of the things they found was that a critical way of improvement is number 2 there, communication between providers and patients / communication. And that is communicating with the patient between visits, whether by telephone or by video conference. They found, at least with their clients, that had a fairly significant impact on improvement in other areas as well. So, Heidi, do you want to pick up now? I apologize.
Sure. No worries. I think that's great. Thank you. There are some, again, minimal requirements for the applicable measures for the claims-based and OASIS measures. The home health agency has to have provided at least 20 episodes of care episodes of care in that year in order for the measure to be one that they use in the calculations. So again, at least 20 episodes of care. In the survey measure, the home health agency has to have submitted at least 40 completed HCAHPS surveys. And if you don't have at least 5 applicable measures, then the agency doesn't receive the total performance score or a payment adjustment and will just simply be paid a standard PPS rate. And HHS or CMS did note that more than 90% of the agencies are in fact reporting on at least 5 measures. One other point to note is that the OASIS-based measures are risk adjusted as well. Next slide, please. So we all know that things can change. Obviously, we've been in 2 years of a pandemic. So CMS actually did say that they would continue to monitor the quality measures, and they may make both substantive and non-substantive changes to the measures. So substantive change examples would be a change in the measure is so significant that the measure is no longer the same, or the standard of performance becomes more stringent. And this will be done through a notice and comment period through regulation. So in other words, there will be a Federal Register notice posted. Non-substantive changes would be things like an updated diagnosis code or broadening age ranges. And again, these are things that will affect it, but really not a whole lot. And these will be done through sub-regulatory guidance. In other words, some sort of notification from CMS rather than the formal notice and comment through the Federal Register. And finally, CMS does leave open the possibility that they might remove a measure. Next slide. I'm not going to spend a whole lot of time on what it would take to remove a measure, but they have a number of factors listed here on this slide and on the next slide. I think some of these things are really interesting. The measure doesn't result in better patient outcomes, doesn't align with current clinical guidelines, or there's a better measure. I mean, these all make complete sense to me as to why CMS would remove a measure. Next slide, please. And this again just continues. I like factor number 8, which is the cost associated with the measure outweigh the benefit of the continued use. And this is actually pretty interesting here. They're going to specifically look at whether or not the cost of data collection and reporting outweighs the benefit of that particular measure. And then they're also looking at the cost of complying with other program requirements. Michael, I think this is one of the few times or one of the earlier times that I've actually seen the cost of a measure, the cost of data collection and burdening actually being formally considered in something like that. But it is useful to know that it is out there. and again, that they will be evaluating these measures going forward. Next slide, please.
Yeah.
One other thing that they may be looking at the measures is they're very concerned about closing the health equity gap, and they have had discussions about social determinants of health. It is not clear at this point if they will be putting measures in place on social determinants of health, but I think that is highly likely. There's been enough discussion about that. So stay tuned and pay attention to what your measures are, because it is quite possible that in a couple of years they actually change some of the measures. Next slide, please.
Yeah,
Go ahead.
Go ahead, Heidi.
I was going to say one other thing to note here is that there has been discussion about PDGM and its effect and how VBP and PDGM interact. CMS has been very, very clear that the value-based purchasing is not affected by PDGM. And we put the quote in here that they believe the model can continue unchanged when periods of care are paid according to the case mix adjustments of PDGM. They did note that they may incorporate functional status as a risk adjuster for the hospitalization measures in the future, but that has not been decided yet. So again, stay tuned. There may be a tweak to one of the measures on that front. Michael, you want to pick up?
Yeah, next slide, Liz, if you would. Yeah, now that Heidi has explained the various items that CMS will utilize to measure quality for purposes of the home health value-based purchasing, let's talk a little bit, if we can, about how the scoring will operate. Since the agency's scores in the baseline and payment year are going to determine the amount of the payment adjustment that they receive in their payment year Medicare payments. CMS will determine what is referred to as a total performance score, TPS, and that score is going to be anywhere from 0 to 100 points, although I don't think I'd want to be the agency that receives a 0 TPS. I suspect that agency won't be around very long. And basically, an agency is going to receive a score on each measure, both for achievement as compared to the other HHAs in its cohort, and also improvement in its own performance in each measure during the payment year 2023 as compared to its performance in the baseline year, which is 2019 for agencies that were Medicare certified on January 1 of that year. For achievement, the agency can receive up to 10 points for each element, while for improvement, the agency can receive up to 9 points. The reason for this difference is CMS's view that while improvement is important, actual achievement of the highest quality level is more so and worthy of a higher score. And also for each measure, the agency is going to receive the higher of the two scores. So for example, if in one particular measure it has an improvement score of 9, but has an achievement score of 10, it'll be given the 10 in that particular measure, quality measure, while if they have a 9 in achievement, a 9 in improvement and a 7 in achievement, they'll get the 9. For each measure, the agency will, so again, this determination is done on an individual measure level before computing the sum of all the measures. Also, as we discussed, each measure is weighted differently, and Heidi will explain shortly the algorithms that CMS uses to compute a score for each element, which are then added together. As we will also explain in greater detail later, the agency is going to receive quarterly interim updates on its scores starting with July 2023, and CMS will be looking at the possibility of providing interim updates in the preliminary pre-implementation year of 2022 to the extent that they determine it's feasible. Also, as we'll discuss, you should pay clear attention to these interim scores, and there's an appeal mechanism to address calculation errors, albeit with a very limited time to submit the request. You should also be aware that the TPS scores and percentiles are going to be reported publicly, and obviously may be used by patients and families in their selection of a home health agency, since they represent what CMS considers to be a proxy for the level of quality that the facility provides or provided in the performance year, as opposed to that of its peers. Next slide, Liz, if we can. Each of these three categories, three major categories, OASIS, claims-based, and HCAHPS, provided a weighting in the scoring process. Additionally, each measure, as we've said, within the three categories, receives an individual weighting as well. And the claims-based category and OASIS assessment categories are weighted somewhat more heavily than the HCAHP one. This reflects the belief by CMS that the first two categories are objective measurements, while the HCAHP survey is more subjective in assessing quality. As such, the claims-based and OASIS assessment categories have a total weighting of 35% each, while the HCAHP survey category has a total weighting of 30%. As noted on the slide, each of the individual measures within the category is also given an individual weighting that is taken into account in coming up with a total performance score. And if a particular category is missing, for example, where there are not sufficient episodes or completed HCAHP surveys, the other elements are reweighted so that you get to 100%. And this next slide that we're going to shows how that works. This again comes out of the preamble to the regulation and shows the breakdown of weights given to each category and each item within the category. So the first column shows the measure for each category, and as an example, the OASIS category as a whole, you will show for all measures is at 35% when all measures are taken into account. In other words, when you don't have any that are missing. Same thing for the claims-based, and at the bottom you'll see for HCAHPS, they add up to 30%. And as another example, if you look at the second column where you have all measures taken into account, TNC self-care is a weighting of 8.75%, whatever your score is in there. So again, when you add these all up, you come up with 35%. And the third and fourth column show how the weights get and fifth column show how the weight gets redistributed when a category is missing. For example, in the third column, the agency may not have had the minimum of 40 HCAHP surveys completed, even if they're a large agency, and as such, the other two categories are weighted at 50% each, and you can see how the individual elements go up. And you see the same thing, same type of activity when you look at the agency that didn't have a sufficient number of episodes for claims, simple number of less than 20 episodes for their claims, and less than Liz, can you move that away so I can see what the column says? Yeah, or claims or HCAHPS, again, or HCAHPS surveys. In other words, neither, and then you're looking at the OASIS category as 100%. What I want to focus on also is you'll note that we've highlighted the acute care, the ACH or acute care hospital admissions during the first 60 days of HHA use. Now, we did this because it is by far the highest weighted category, demonstrating the importance of hospital admissions on both the quality and cost savings for the program. Obviously, this is an area where you want to score highly, even with all the elements present, as it comprises more than 25% of your total performance score. Also, the care that the agency provides has a major influence on whether there is a hospitalization, which is why CMS believes that not only does it have an impact on cost and savings, but also again is an important proxy for quality. Heidi, do you want to talk a little bit, if you can, about slides 25 and 26, where Heidi can show you how this translates into a score?
Sure. So again, what these measures add up to are the use in the improvement and the achievement scoring. So we have some concepts here: threshold and benchmark. So the achievement threshold is the 50th percentile of all home health agencies on a particular measure for your cohort in the baseline year. Wow, that's a mouthful. The benchmark, meaning where they would pretty much like everybody to go, is the mean of the top 10% of the scores for all HHA's performance for that given measure during a baseline year. And so the difference between the threshold, in other words, the 50th percentile, and the benchmark, which is the mean of the top 10% of the scores, is the achievement range. And that achievement range is used to calculate your achievement score. Similarly, the improvement threshold, again, remember we said improvement is you're being compared to your baseline year, which is calendar year 2019. So the improvement threshold is your baseline year measures. And then the benchmark is, again, the mean of the top 10% of the scores for all home health agencies for that particular measure. And your improvement range is, again, threshold to benchmark. And again, if your home health agency exceeds the mean of the top 10% of the scores, in other words, if they exceed the benchmark on either the achievement or the improvement scores, then you automatically score a 9 or a 10 as appropriate. For those, next slide, please. For those who are mathematically inclined, this next slide actually has how this is calculated. So you can see here, the achievement score is the performance score minus the threshold divided by the range, which is, again, your benchmark minus your achievement threshold, times 10, and that gets your achievement score. And then the improvement score is, again, your performance score compared to your improvement threshold, which again is 2019, divided by the benchmark to the minus the improvement threshold. So that again tells you sort of, it normalizes what your improvement score is and then times 9. So you can actually figure these out yourself and see what your achievement scores are and your improvement scores are, and you can calculate those yourself. Michael, next slide.
Yeah, and I would just make one comment. I would just make one comment on that, and then one on 26, and that is that while it may be a little dense the numbers do work, having worked through them. While the reasoning and the rationale for the algorithms may be a little dense, CMS didn't receive a single comment on them in the notice and comment period from the proposed rules. So they obviously either work or they're too dense for anyone else to figure out, one or the other. This next slide is also taken from the preamble to the regs and shows how the payment adjustment for the payment year is calculated for a hypothetical set of agencies that form the cohort for the particular year. And in the hypo, you have 8 total agencies. So this is how the score gets applied in order to compute a payment adjustment. The important thing to recognize on this is that last column. And there is a tremendous correlation. There's a correlation between the total payment score, as you see in the last column, and the first column in terms of your the payment adjustment. Let me walk you through it a little bit. The second column shows the agency's total performance score. And then in step one, you look to the total amount that Medicare paid the agency in a prior year. And for Home Health Agency 1, that was $100,000 in total payments. You then apply the 5% payment factor to the total payment amount, so you come up with a $5,000 potential payment reduction or increase for HHH1 in that as related to that prior year. In the next column, you divide the total payment score by 100, multiply it by the amount that you come up with in step 2, and in the case of Home Health Agency 1, this is $1,900, and to come up with what CMS calls the linear exchange function to be applied across the board to all agencies, you take the sum of the 5% reduction of $172,611 at the bottom there in step 2, and you divide it by the bottom number in step 3, and it gives you a linear reduction function of 1.931 that's applied across the board. This is the way they account for the difference and bring in all the agencies as they try to apply this. And you have several further calculations that you can review in the preamble and the chart, but the critical column is the final one, which shows the percentage reduction or increase that is going to be applied to the Home Health Agency's payments in the payment year, this first one being 2025. According to CMS, this linear exchange function and methodology would result in no payment adjustment for an agency that scored at the 50th percentile. And you can see that the lower the hypothetical agency score, the greater the payment reduction that it'll receive in the payment year, and the higher the score, the greater percentage of increase it would have in its payments. So for example, look at hypothetical number 1, where the agency had a TPAS of 38, and you have a payment adjustment for the payment year of minus 1.331%. And then you look at Home Health Agency number 4, and there they had a score of 85, and they would get a 3.208% increase in their payments in 2025. Now, if we can go to the next slide, Liz, if that hasn't completely confused the world. During the performance year, the home health agencies will receive quarterly performance reports that reflect 12 months of rolling data on measures, achievement thresholds, and benchmarks. Because of the different times of submissions, the interim reports will have a year's worth of data for different periods, for different categories. And the first promised report would be released in July 2023. However, the preamble also states that they're going to try to provide interim performance reports during the learning year of 2022, if feasible. You're going to be able to retrieve your reports on the IQ IES, and you'll be able, and CMS is going to provide a preview annual report in August preceding the payment year, and it's going to provide the final calculations at least 30 days prior to the payment years. As we're going to discuss, it's critical that you review these reports carefully. First of all, they'll show you areas where you need improvements and where you're strong, although I expect that agencies are going to be tracking these reports in advance with software. And second, we'll show shortly, you have the ability to seek a recalculation if you believe the report is inaccurate. And the final report that you receive approximately 30 days before the start of the payment year will have accounted for any changes that occur either in the groupings as a whole or for any other changes on the individual agency level during the appeal recalculation process. Liz, next category. This is a slide again from the preamble to the final rules that shows the timeline for the 2023 performance year and 2025 payment year and the data, what's going to be included in the data that you get on these performance reports. Just as an example, in the October 2023 IPR, for the OASIS-based measures, you're going to get 12 months ending in June 30th, 2023, whereas for the HCAHPS and claims-based measures, you get 12 months ending in 3/31/2023. So again, I expect that most agencies are going to have their own, are going to purchase software or develop their own software to be able to be tracking what's going on here. Next slide, if we can, Liz. As I mentioned earlier, there's an appeal process where an agency can submit a request for a recalculation, and this can be submitted for interim total performance scores, but most importantly for the preliminary annual report that you're going to be provided in August preceding the payment year, namely August 2024, and you'll have 15 days from the CMS posting of the scores to submit the request with full data justifying any change. So again, that's why you're going to be modeling this with software, I'm sure, along the way. You can also seek a reconsideration of any decision on the recalculation request or decision to deny the recalculation. But again, it's got to be submitted with supporting reasons for the data within 15 days of CMS's notification of the recalculation request. We can't repeat frequently enough that it's critical to stay on top of the information needed to determine the accuracy of the reports. And again, I expect you'll be purchasing vendor software to be able to do this. And there's also a process for seeking an exemption from filing data for extraordinary circumstances, which is further discussed in the preamble. We don't really have time to discuss it here, but it's very limited. And if you have questions on it, feel free to reach out to us after the presentation. Can we go to the next slide if we could? Next two slides are just some tips, which are pretty obvious. First of all, you want to use 2022 as your dress rehearsal, or as one person I heard refer to it as if you look at it in terms of football, it's your preseason. You want to focus on the operational issues, obviously, focusing on the accuracy of, as Heidi mentioned, of OASIS reports, and ensuring that review teams are consistent when they're reviewing these in their treatment, so that you don't confuse staff in the field. You want to focus on what drives improved results based on clinical care. For example, what types of clinical improvements will lower your hospitalizations and ED use without hospitalizations during the first 60 days. We've gone over tracking the interim performance reports and preview annual reports, both for accuracy and then again for areas of improvement. And if you can go to the next slide. Be prepared to file your appeal requests again for recalculation within the 15-day time frame. And here's one we haven't talked about. CMS is going to be providing educational materials to be released during the 2022 calendar year. And an example of this is the upcoming webinar on February 10th. Frankly, had we been more prescient, we might have scheduled this one for March rather than February. But we weren't aware of this at the time, and you can register on the link that we've given you, Expanded Home Health Value-Based Purchasing Model /CMS Innovation Center, for registration details, and also on the links that Heidi will be talking about in a minute. Heidi, do you want to finish it up here?
Yes. So again, just to summarize, we're in calendar year 2020, so there's no model in effect for anybody this year, and this is not a performance year. This is, as Michael said, it's the preseason, it's the dress rehearsal. The way I say it, it's really an opportunity for you to dive into your systems and look at your data, and there's no repercussions for the changes that you make now, but you need to make the changes now in order to put in place your methods and your processes and your guidelines, et cetera, and your training and education of your staff, so that you can achieve the better performance when compared to your 2019 data. As Michael said, the data is going to be available on IQIES. There's the link here. I'm sure most of you have gone to it again. So the first performance year is next year, 2023, starts January 1st. And again, they're going to be collecting data all year, 2023. 2024, they're going to be crunching the numbers, and then calendar and late second half of 2024, hopefully sometime in the third quarter, they'll announce the payment adjustments, and then January 1 of 2025, you will have your first year of payment adjustments. Next slide, please. Here are some resources for you to go if you want to dive into more depth. Here's the link to the final rule. They actually have a home health value-based purchasing website, and they actually have a newsletter that you can get and sign up for. That's all we have for home health value-based purchasing. Michael, did you want to talk very quickly about CJR?
Very quickly about it. Again, you can get a full webinar on it. You can listen to the full webinar on this that you can receive off of our Lyles Parker website, www.lylesparker.com. That's on here. Basically, the Comprehensive Joint Replacement Program was an initial pilot program that was made mandatory for approximately 800 hospitals in 67 MSAs. It was later made voluntary in only 34 MSAs by the Trump administration, and all Texas MSAs that were in the original 67 MSAs are also included in the reduced number. In 2021, the Biden administration extended the pilot for an additional 3 years, and it's a program that puts hospitals at risk for a portion of payments for lower joint replacements, mainly knees and hips, for not only the care provided in the hospital setting, but also for the following 90 days. And this means that downstream providers are extremely important in the process, and hospitals are allowed, but not required, to share risk and reward with certain categories of downstream providers, including home health agencies. You have to have a specific contract, which should be worked on with legal counsel. There are certain ways for what we call collaboration agreements with downstream providers. And there are certain waivers that have been issued for such things as the anti-kickback rule. And the importance is that it's the only mandatory disease bundle pilot. And I think the extension is significant for their understanding of disease provisions overall. But I would also mention to you that that you're going to see, I think, a greater emphasis on overall risk taking in the future by providers rather than just disease specific, with a few exceptions. But that's just prognostication. Heidi?
Yeah. So there are a whole bunch of slides here, folks, on CJR. Again, we're not going to go through them. We did want to leave them in so that you can look at them if you want to. And again, there is the other information there. Liz, can we jump to slide 63? Very briefly, want to mention that among the other things still happening is not just CJR, but also accountable care organizations. And you should be aware of these. Again, we're not going to talk about them in depth at all, but accountable care organizations are still in functioning. Yeah, we've got these moved around a little bit. Oh, well. So accountable care organizations are still in place. And we do want to make sure that you're aware of these. More than a quarter of Medicare fee-for-service beneficiaries are going to be in an ACO, and there are a significant number of ACOs in Texas. Liz, if you wouldn't mind going to slide, let me see, what is it? 66. just give you some numbers here. As you can see, there's the 55 ACOs with the shared savings program. The next generation ACO model just wrapped up, but there's also an ESRD model, although we've only got a couple of those in Texas. So if you're going to run into an ACO, it's going to be the shared savings program. But again, the ACOs do bring in care providers, ancillary care providers like hospices and home health agencies. So you may very well get looped into an ACO and participate in the shared savings program that's run through an ACO. There's a whole bunch of slides here on ACOs. Again, I'm not going to go into these in depth because we're out of time, but they're there for you to review. Finally, we have also a couple of slides on Medicare Advantage. Mike, did you want to talk real briefly?
Yes, real briefly. Medicare, the Medicare Advantage, keep going till you see Medicare Advantage. Oh, well, back. Oh, no, I'm sorry, keep going forward. Well, rather than going through all this, the slides on Medicare are on here, right here. Basically, Medicare Advantage, as everybody here knows, is becoming more and more popular. It's where private insurance companies run Medicare programs, and I believe this year they're up to something like 40% of all Medicare beneficiaries get their care through MA. And under the Medicare Advantage program, for the year 2020, CMS expanded the types of benefits that the plan can offer supplemental, what we call supplemental benefits, to include such things as home and personal care that you can't get in original Medicare. And beginning in 2021, the plans could offer certain types of non-medical benefits, including some that address what we call the SDOHs, or social determinants of healthcare, for chronically ill beneficiaries. We've seen a major expansion in these offerings, where plans are starting to pick them up in limited circumstances, including home and personal care in certain circumstances, and it's worth checking out with your plans. It's discussed in far greater detail in the slide deck, and also, again, if you go into our website and listen to the July 2020 webinar for TAC, you can hear a far greater discussion. It's a real opportunity. It's a real opportunity for agencies. It can be a real opportunity for agencies that may not exist in the traditional Medicare program. Liz, we have a couple of questions that we can go through very, very quickly if we can.
Sure, let's take a look. Where can we find the information to register for the webinar on HHVPP? By CMS. It is, I believe you can get that or get to it from Heidi. Let me get to the last. There's a link on the slides. I think if you share to everyone,
which we are sharing to everyone. But also, I think if you go into the CMS Expanded Home Health Value-Based Purchasing website at https://innovation.cms.gov, innovation models, blah, 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 that we've got on the second bullet on page 30, on slide 32. I think that'll get you there as well. If you have any trouble, feel free to reach out to Heidi or me on that. The handouts themselves are going to be, I believe, are going to be placed on the website on TAC's website. Are they going to be sent to the attendees by TAC?
Yes, all attendees of today's presentation that registered will get copies of these slides.
Click on then just click on all you have to do is click on slide, where are we? Let's see, wherever I
32.
32 to Expanded Home Health Value-Based Purchasing Model, blah, 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 blah. That'll get you there. That'll get you there as well. In terms of also one other point, in terms of both slides and a recording of this presentation, you can pick that up off of the Lyles Parker website in the near future.
Yeah. We have one other question. Someone asked, how do you find out your 2019 score?
I think that ought to be on the IQES, is it not?
Yes. Yes, that should be on IQES, and because it was 2019, that data should already be crunched and available.
Yeah.
Okay. Well, that's all the questions that people have posted. So if anybody does have any further questions, they can feel free to reach out to Heidi or Michael directly. And that concludes our webinar for today. So thank you all for joining us, and enjoy the rest of your day.
Thank you all. Bye-bye.
Thank you all. Bye-bye.